Good afternoon, attendees from the GCC and all over the world. Today, I would like to welcome you to our second GCC Rheumatology Conference in its first virtual version. We'll start our day with exciting sets of workshops, starting from how to create a clinical registry in rheumatology, and another workshop on how to conduct a clinical audit in rheumatology practice. The other sets of parallel workshops would include an exciting workshops on mentorship in academia for rheumatologists, early career rheumatologists, as well as residents and mentors. And the last workshop would be on interpreting autoimmune labs, pitfalls, and pearls. And then we'll move on to the opening ceremony of the conference. And we'll end up our day with an interesting session, first of its kind in this conference, on patient advocacy groups in the GCC for rheumatic patients. I hope you had an interesting and an exciting and an enjoyable experience in this conference. Thank you so much for attending and wish you the best out of this conference.
Dear colleagues, Assalamu alaikum. It gives me a great pleasure to welcome all of you to the second GCC Rheumatology Conference that is hosted here in Muscat, Oman. However, it saddens me that we had to change the platform of the conference from face-to-face to a virtual one, and I'm not able to greet you in person. But the decision stemmed from the National Supreme Court recommendations, as well as the organizing committee having your safety as a priority. The aim of this conference is to advance scientific research in the field of rheumatology, both regionally within the GCC countries as well as internationally. Therefore, by creating a platform such as this conference, it will enable us to share and discuss our research in the field. It would also advance research through enhancing professional network and therefore collaboration on future multi-centered and multinational research projects. The ultimate gain in mind is to form an alliance whereby together we can set the GCC in the global map of research. Although Oman is hosting the conference, however, the success of the GCC conference is completely dependent on joint efforts. By the contributions from our pediatric rheumatology colleagues across the GCC countries, we were able to establish a solid scientific content of the pediatric program, which I promise you will be very rich in content. The first day of the conference will be loaded with interesting workshops on how to create a registry, how to conduct a clinical audit in relevance to our practice, how to develop an approach to immunological investigation, in addition to many workshops related to academia. The second day of the conference will be a day full of pediatric rheumatology sessions. The pediatric rheumatology program will contain 7 topic reviews, 10 research abstracts, 5 challenging cases, as well as a workshop on autoinflammatory disorders. In addition, there will be many topics of interest that will be running simultaneously in parallel in the adult program. Finally, the last day of the conference will contain topics that will be of interest to both pediatric and adult rheumatologists, including sessions on systemic lupus erythematosus, antiphospholipid syndrome, vasculitis, connective tissue diseases, as well as the effect of COVID on patients with rheumatic diseases. So you can see the program is really rich and packed with the most up-to-date scientific content, and we're all very excited to start the conference together. Once again, I would like to thank you for your participation in the conference and hope that we enjoy the next few fruitful days together. And most importantly, hopefully that we'll be able to meet each other very soon, inshallah. Take care.
Good afternoon, ladies and gentlemen. Dr. Ali Al-Shirawi, chairman of the second GCC Rheumatology Conference, and I will be moderating this session with His Excellency Dr. Ahmed Al-Mandhari. Dr. Ahmed Al-Mandhari, he contributed significantly to the development of health services in Oman. He is an expert in the patient safety and health equality, starting at Sultan Qaboos University Hospital as head of a quality department and moving on to be deputy director of the hospital for clinical services and moving up to be the director general of the hospital. And from there, he moved to the Ministry of Health to be the director general of Quality Assurance Center. He built that center from scratch at the Ministry of Health. He assumed the current regional director of the East Mediterranean Office of the WHO on the 1st of June 2018. His workshop is on how to conduct audit a clinical audit in rheumatology. And we welcome His Excellency Dr. Ahmed to this workshop. Thank you, Dr. Ahmed. Welcome.
جزاك الله خير جزاك الله خير دكتور علي. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. And thank you very much for your kind introduction and kind words, Dr. Ali. It is my great pleasure and honor to be with you today, in fact, in this very important workshop in 1 hour. And it is my great pleasure and honor, and thank you for the organizing committee to invite me. I'll do my level best to be brief and concise as well as precise in sharing with you how to conduct a clinical audit in general, but also focusing or sharing some on in rheumatology. When it comes into the basic concept, it is almost the same, and the ABCs are the same regardless of the specialty. I used to run this workshop in Oman, and I was there at the University Hospital, and then when I moved to Ministry of Health in almost 3 days or 2.5 days. It is a very lengthy, comprehensive workshop, that is composed of theoretical, very interactive sort of discussions with the participants, as well as practical sessions. So it was divided into 50-50. And then it was, I remember, followed up by a refresher course in which, in between the main workshop and the refresher course, some sort of mini project in which participants will go back to their organizations or institutions. They will run a small project as a clinical audit, and then we will come back again after 3 to 4 months, sharing these experiences and how it led into improving the knowledge and the skill of those participants, and therefore taking it further, implementing it on their day-to-day practice. This workshop, 1 hour, it will be divided into 2 halves, as shown here in the outline. I'll be talking about what is clinical audit and the basic concept, and then the terms and the definitions that are commonly used in a clinical audit. Then I'll stop for questions and answers, for 10 minutes. Then I'll go to the second half, in which we will discuss, the stages of a clinical audit and the recommendations based on that discussion, and then another sort of questions and answers. Now, I'll start my first part. What is clinical audit? What do we mean by a clinical audit? I'm sure, colleagues, you came across this word audit. And to me, in fact, when I first heard about this word audit, and also based on my personal experience with colleagues at different specialties or different levels, either physicians, nurses, other, allied healthcare professionals, the reaction is a bit negative, bit defensive, bit resistant about the audit itself as a word. And, there was some sort of dissatisfaction or unconvertible reaction from all of us when we hear the audit in the medical field. Before I go into the detail of that, I just wanted to share with you the source of this word audit. It is a Latin word, and its source, came from the word audire, which means to hear, and the noun is defined as an official inspection of any organization's account, either financial, technical, or you name it. And the verb audited or auditing is to make an audit, to make an assessment or a review of any organization, as I said above, account. Now, when this, audit as a terminology and definition is used in healthcare system, it came into different stages and it was done at different areas and specialties, and definitely you will come across it, like management audit, which is responsible for auditing the admin and finance, or maybe sometimes the legal aspect of any organization. And then medical audit, which is focusing on examining the work of doctors and physicians, regardless of their specialty. We have a clinical audit, which is a bit bigger. It examines the work of the big team, the physicians, the nurses, like in rheumatology, for example. The rheumatology service is composed or given by a team. The rheumatologist is leading that team, yes, but they have nurses, they have physiotherapists, they have, some other healthcare professionals, in that team. So it is a bit wider compared to the medical audit. We have another name, which is or type, dental audit. It is very clear that it is focusing on the dental services, nursing audit focusing on services given by nurses, and then financial audit, which is responsible for assessing, reviewing the financial status of any organization. Now, when it comes into the definition of a clinical audit, there are many definitions, and it is really confusing sometimes, but I selected one of the best definitions given to this sort of activity, important activity, by NICE, National Institute of Clinical Excellence in UK, which is still valid, from 2002, still valid. It says here, a clinical audit is a quality improvement process that seeks to improve patient care and outcomes through systematic review against explicit criteria and the implementation of a change or changes. And I highlighted the keywords in that definition. And on the right side, you may see the graph, which is summarizing to us the cycle, of any clinical audit activity. It is a cycle. It is ongoing, continuous cycle. It never starts from A and then stops at D or C or Z, or it is a continuous cycle. So the cycle here, as I said, it is a process that seeks to improve patient care and outcomes by asking, what are we trying to achieve? What is our main target of this activity? Which service, which part of that service? And then you go to assessing, doing the assessment. Are we really achieving it by collecting the data, either through a checklist on, say, for example, clinical care, prescriptions, laboratory findings, patient assessment, and physical examination, signs and symptoms, or patient satisfaction, different types of outcomes, different types of data collection activities. And then you will identify, based on the outcome of that exercise, are we really achieving it? Are we below the standard that we have made, above, or in the same line? And then you will try to propose changes, into the service itself. based on the audit and the focus of the audit, doing something to improve and make it better. And then you will come after some time, a month, 2 months, 6 months, a year, based on your decision from the beginning of planning the activity. Have we made things better? Have we made a change? And there are tools to assess whether you have made a change or not. And then the cycle will continue. It is non-stopping process. And this is something I always say. It is non-stopping process. You start now and it will go forever. And even if you reach 100% in one aspect, you still continue adding to reach even better than 100% in that area. What clinical audit is not, sometimes we tend to confuse between a clinical audit activity and some other wrong activities or wrong perceptions about the clinical audit. It is not a resource management tool. Never use clinical audit to control resources, to control funds, and to share it, say, for example, with the hospital administration or department administration, telling them we have 1,000 Oman Riyal, for example, as a budget for that service. And now the clinical audit shared, told us, no, we don't need 1,000, reduce it to 500. Or even admin people, they'll say, reduce it to 500. Do the clinical audit, how to reduce the budget to 500. Never use it as a resource management tool. You may use that saved money for some other developments and improvement. Never use to threaten individual clinicians. Otherwise, you will spoil and damage the spirit of the aim of that clinical audit. It is not a batch of computers or a set of statistics. We have the best computers, the best statisticians do the collection, have it in a very nice graphs and figures, a nicely colored report, and that's it. It is not done that way. Otherwise, it will be a waste. It is done for the aim, as I said, of improving the service. It is not a competition between different healthcare professionals or teams or clinical, physicians. Even in the same team, it never used in that way. Otherwise, it will create a very negative sort of environment and sometimes defensive, reactional things that will not, will do more harm than good things, when it comes into this activity. To share with you history of a clinical audit, there's a long history on that, but it started, in fact, with one of the, Arab Muslims physician during Al-Abbasi's era, with someone called, Sinan bin Thabit, who is a physician in Baghdad, supervising healthcare services during 3 Khalifas that time. In fact, he decided to do this activity, although it is primitive, after a death of a patient. And then after that, things went into different levels. And then when it comes into it as a global activity, you remember, the mother of the nursing care, modern nursing care, Florence Nightingale, when she was involved during the Crimean War, in which, she was leading a group of nurses giving care to wounded soldiers. And then she found that many of those soldiers, either they die because of septicemia, or they, ended up with amputations of their limbs due to infected wounds. So she decided to develop standards and guidelines and protocols for dressing of those wounded soldiers. And she trained her nurses, and then she assessed the outcome after implementing that hand hygiene and the septic, procedures. And then she found there was a reduction in the mortality from 40% to 20%, which is really huge. And also in the amputations and the infected wounds. So she decided to continue that and introduce it to the area that she's leading. And then in USA, in fact, it came as a part of the profession through someone, called Ernest Goodman, who is a surgeon in USA. He faced a lot of difficulties and resistance from his colleagues. And in fact, they throwed him from that university at the beginning. But then he insisted. And then he was known to introduce, what is called the first true medical auditor in the world. And he introduced the end result idea, in which he assessed patients he operated on after some time. And it led into really a very positive culture. And then from there until the year 1990s, it took almost 130 years for health systems to accept the idea. And if you go to UK or Australia or Canada or US, they'll be having a different developments in that. But it took the whole profession 130 years to accept it as a very solid, essential element in healthcare system. And a very good example, the clinical audit was formally introduced in 1993 to the UK national healthcare system. And I'm sure Dr. Ali, being there, studied, for his under and postgraduate, he came across such activity. Now I'll take you to why we need a clinical audit. There are many driving forces for us, pushing us to do a clinical audit. One of them, it is, as a result of local clinical interests. It is an interest within the clinicians themselves, and they decided to that activity. It is either maybe because a result of a clinical incident reporting. The hospital developed an incident reporting system. Based on that system, they need to investigate, they need to audit. So it is part of a quality assurance system like ISO or GCI or ACI to comply with regional or national initiatives or standards. Like, for example, in Oman, the Minister of Health decided that hospitals should do a clinical audit. University hospital asked also maybe some departments do a clinical audit as part of the quality assurance system to inform patients about surgical results, because patients, they started complaining, for example, or they raised their voice about it, similar to what has happened in UK, and I'll share with you examples. To drive continuous quality improvement as one of the requirements of an international or national accreditation system, for example, for healthcare regulation. So there are many driving forces. Why we need it? The aim of conducting a clinical audit, there are many. I'm sharing with you some, to improve patient care. And that is the ultimate aim of doing a clinical audit, to ensure that patients are receiving the best clinical care possible based on latest developments and latest evidences on that area or that field, to improve multidisciplinary working. As I said, healthcare is never given by one person. It is given by a group of people and a team. So running a clinical audit, definitely, it will focus on the technical, physician side, nurses side, and other sides that are playing a role, to maximize the use of, and outcomes from available resources. Like, for example, I have an MRI, or I have the best machine in my hospital. How to make sure that that best machine is well utilized to improve patient care. If I do 1,000 MRIs in a month, how many of these are really adding value to the care or the decision that we take to care for patients? If it is 20% or 80%, it will make a difference. And here comes the importance of saving resources and improving patient care. To meet the standards of healthcare set out by the healthcare system itself, like in UK, they said, okay, rheumatology services, they have to follow 1, 2, 3. And then rheumatologists in different parts of the country, they'll say, okay, are we really meeting these standards? Are we adhering to what is given to us in 1 year or 5 years? So that is the aim of doing it. Why a clinical audit in rheumatology important? This is your area. I will not go into that because you are the expert. I just thought to share with you reasons, driving forces why we need to run an audit in rheumatology. Rheumatology and musculoskeletal diseases is a diverse group of diseases commonly affect the joints, but can affect any organ in the body. And to me, this is a very strong driving force and reason to make us really assess the services we are giving to those group of patients, to make sure that they keep healthy. Their quality of life will continue at its maximum level, either from the first moment of diagnosis to the control, of their diseases and improving their quality of life, because it is a very disabling to have such conditions. There are more than 200 different diseases affecting both children and adults. This is another reason that will push us to make clinical audit. They are usually caused by problems of the immune system, which is one of the difficult systems to control. It leads to inflammation, infections, gradual deterioration of joints, muscles and bones, and may later on leads to disability and crippling and, losing of life quality and dependence. Many of these diseases are long-term and worsen over time. That is another reason. They are typically painful and limit function. Another reason that will make us or push us to do the clinical audit and make sure the service is of high quality. In severe cases, these diseases can result in significant disability, as I have mentioned, having a major impact on both quality of life and life expectancy. So these are the reasons. Now, just in this graph and the next graph, I want to share with you, if we do a clinical audit, as I said, it is a cycle. Does it mean we stop and we made an improvement, we stop there? No. And that is the risky part of it. If you do an audit, notice some improvement, and then you will say, that's it. It is very risky. It is going to lead later on to deterioration of insurance. And in this graph, you see that, we made the first audit here, in period 1, and then you took action for improvement in the middle, and then you go for another audit, and definitely you will see an improvement. And then we go to the next stage, audit number 1, audit number 2, and audit number 3, and in between there are actions that we need to take. And here comes the importance of keeping the cycle. I assure you, if you do it in a very scientific manner, definitely you will see an improvement. And I experienced myself, in fact, when I was at the university, either in quality or then later on when I moved to the Ministry of Health. I've seen it myself, either in terms of staff satisfaction, in terms of patient satisfaction or relatives, and in terms of the clinical outcomes, even financial and money saving and these sort of things. It really helped a lot. Now, in these coming 4 or 5 slides, I want to share with you real examples from audits done period 1, and they repeated it either once or twice, and they continue doing it, but the improvement. This is an audit done in Denmark, on the quality of care given to a group of patients coming to general practice. Like, for example, patients' information documented. And this is done for, patients coming to a general practice clinic. I just highlighted the one in red boxes. Patient information documented. In first audit, it was 32%. And then it improved in the second audit to 36%, with suggestions and recommendations for improvement. And there is a significant improvement. Improvement is really significant. Percentage of complete drug prescriptions, it improved significantly. Another example, estimated length of stay, it improved significantly. It reduced, from 21% to 17% with significant improvement. Action on described clinical problems, actions were taken on time, and it led into improvement. So this is an example. Another example from Australia, in which, in fact, it was done in one of the general practice clinics there on care given to coronary heart diseases. And if you notice here, the red arrows, total number of patients on coronary heart disease register. 3 audits done, the basic at 0, if I may call it, or period number 1, 2, and 3. And you notice the improvement from 64 to 84. Another improvement, percentage of patients with coronary heart disease on aspirin. It started 33%, ended up of 71%. Percentage of patients with coronary heart disease whose last recorded blood pressure within the range. Started 27%, ended up 48%. Another example from Australia also, about those who are attending anti-smoking clinics. If you look at the p-value here, all of these values are significant. They did audit number 1, and they did another audit after some time, and then it led into significant improvement: 74%, 87%, 14%, 23, 22, 38. So it led into 11%, 21%, followed up. So there is a significant improvement. Another example from South Africa on patients also attending a general diabetes clinic, which led into improvement in the care. Period number 1, like, for example, weight recorded at each visit. It started with this much, it ended up with this much. Annual retinal screening recorded. It started with this 15%, ended up to 40%. So in these red boxes, just shared with you examples, how it led into improvement from period number 1, 2, 3, and 4. And I'm sure if we go now to the latest developments, it is much, much higher. Last example is from UK, methadone prescribing in general practice. And there's, if you notice here, the first audit, gray color, dark gray. Second audit, light gray color. And you see, like, for example, named pharmacists in the notes. It has improved. Patient in contact with the community drug team and street agencies. It led into some changes in the hepatitis status discussed. It improved. HIV status discussed. It improved. So there is an improvement. I'm sorry, maybe this is another example, but I'll just skip it for the sake of time. Now I want to share with you two examples of a real clinical audit in the history of NHS. And I'm sure Dr. Ali and colleagues who are trained in UK have come across it. The first one is the report of the public inquiry into children's heart surgery at the Bristol Royal Infirmary Hospital. It happened that from the period 1984 to 1995, there were 53 cases in which reported 29 of them death among children, open heart surgery, and 4 ended up with brain damage. The hospital was not having a quality system, monitoring system, although there were some whistleblowers in that hospital, the anesthetists, for example, and the nurses, but nobody listened to them. The NHS started, in fact, this investigation based on public pressure. And if you remember the driving forces, the community there, especially the mothers of those children who died or ended up with brain death, they raised their voice. They met the hospital administration. They ignored them. They met the local authority, the district authority. Then what happened? They went to the media. They went to the newspapers and the TVs. And from there, it was like a big mess. They started investigating at higher levels. And they concluded in fact, the investigation is one of the lengthy investigations in NHS. It started October 1998, and it took them 3 years, almost 3 years. They reviewed hundreds of thousands of documents. They interviewed tens or thousands of people. And they ended up with 4 main messages. The main root causes they identified: individual failings. Individual surgeon, nurses, and others did not take their responsibility as it's supposed to be. There was a poor teamwork and communication locally within that unit. And from that unit to the hospital administration, because there was no regular meeting, there was no regular updates. And general failings in the NHS, because the NHS that time doesn't have a monitoring system. That's why they introduced 1993, the 93, that although they introduced it 1993 and then it developed into 1997 white paper, but still monitoring was not there. So they concluded in that report, a brief summary. It says here, although the origins of the inquiry lies in events in a small part of one NHS hospital in Bristol, the lessons drawn by the inquiry team apply to the whole NHS. And then they say, put simply, the report aims to set out the way that the NHS should operate at the level of the trust or service, and also show the individuals in it. And they said, last, it is written as a demand on behalf of patients for change in the culture of the service, both within the NHS itself, but also within the individual units and hospitals. Another example is, there was an estimated 400 to 1,200 patients died as a result of poor care over the 15 months between January 2005 and March 2009 at Stafford Hospital, which is a small district general hospital in Staffordshire. And that was another nightmare to the NHS leadership. And also, again, it was not discovered by the hospital. It was not discovered by the hospital monitoring system. It was raised by the patients, their families and relatives, And this is just an example of, sorry, to go back. Sorry, I need to go back. Yeah, I mean, they concluded with a long list of reports, but I shared with you this, summary. Incorrect priorities do damage. And the main focus of the hospital administration that time, as I said, was saving money by reducing the number of the patients, by reducing the number of the staff and the physicians, and it led that sort of wrong priority. It led to losing the focus, by at least some leaders on what is their main target and main job. And then it says here, in some organizations, in the place of prime directives, the needs of the patient care should come first. Yes, we have difficulty in the budget, but our patient care should come first. And the goals of hitting targets, it should come first. Hitting targets and reducing cost, then reducing cost. Listening to and responding to patients' needs then become at best secondary aim to them. It came to the second, they were shouting, they were raising their voice, they were whistleblowing, nobody listened to them. Then the other unfortunate culture there, bad news becomes unwelcomed. If a patient developed a complication or a side effect or died, the administration was not listening to them. And they were putting them aside. They were, in fact, threatening them. So that was the culture created in that hospital. And then the other conclusion, responsibility is diffused and therefore not clearly owned, neither by the surgeon operating or the head of the department or the hospital administration or the NHS. It says here, responsibility for oversight and remedy for quality and safety concern was and is still to some extent diffused in the NHS in England, with that responsibility divided among many agencies and with unclear or at times non-existent lines of coordination, communication, better recognition, and follow-up for action. And they concluded that when so many are in charge, no one is. And this is applicable to many of the problems that we are all facing, and investigations that we have done. Now I'll go to the last part of this presentation, which is the criteria for a good clinical audit. In order for you to say, yes, I have now a system, I am really happy with it, it is not based on a person or individual. No, even if I leave, it will continue. It should be part of a structured program in the department or in the hospital with regular, frequent, activities and monitoring and meetings and follow-up. Topics chosen for that specific audit should be selected based on criteria, very clear criteria. It should not be selected haphazardly. It should be focused. And there is, in fact, a system to do, selecting high risk, for example, high volume, it means seen by, seeing a large number of patients, high cost, or it is reflected in a national clinical audit. And there is a system how to it is called quality impact analysis, to identify which service or which area that I need to do the audit. Service users should be part of the clinical audit process. The patients and the relatives should be involved in that sort of assessment, to hear to them, to listen to them, to hear from them and listen to them. Should be multidisciplinary in nature. It should not be only clinicians. It should be the whole team participating, because at the end, the service is given by a team. And whatever improvement you want to do is by that team. Should include assessment of process and outcome of care. And I'll share with you what we mean by process and outcome. The standards should be derived from a good quality guidelines that are evidence-based, latest updated guidelines. The sample size of that audit should be adequate in number in order to make sure, yes, it will reflect the real life there. Managers should be actively involved. Hospital administration, the director, the head of the department should be involved in this activity from day one. From day one, you start thinking about it and planning for it. Otherwise, you will face difficulties at the end when you come out with recommendations and actions to be taken. Action plan should address the local barriers to make any change, because you will come out with the recommendations, and definitely these recommendations will need you to make changes. So you will look at what are the barriers. Like, for example, if we want to reduce the number of MRIs in a month based on that audit, you need to look at what are the barriers. And I still remember when I was at the University Hospital Director General, after Dr. Masoud, Allah yadhkuru bil khair, and we made, that time we had Acinetobacter in the ICU, and Dr. Abdullah Bil Khair with his team decided that consultants, no more than 2 people should enter the ICU, and consultants and all those who are coming into the ICU should get out their white coat, should clean their hands. There was some initial resistance from senior consultants and professors, but then when we identified the barriers, it went very smooth, and they were really very cooperative because they understood the benefit behind it. Re-audit should be applied, as I said. each audit should have a local lead, someone whom you appoint as a local lead or a leader of that audit activity to make it really supervised, well supervised. Successful clinical audit, it has to have the right people with the right skills in leadership, for example, in medical audit expertise, in statistics, in the technical expertise as well, in the data collection, in the facilitation skills. So you have to have the right people, the right mixture of the people. Otherwise, if you have one person who is not really well-oriented, well-equipped, the whole team will face difficulties. Now, for a clinical audit, to make it also a successful, you have to have the right environment, in that hospital. As I said, the culture, a very receptive culture with a positive attitude on the benefit of the audit, the benefit of the reviews, with high positive, good level expectation out of that audit activity. So the culture and the structure within that hospital is really needed. Now, people sometimes they tend to be confused between a research and a clinical audit. And my main question, if I want to differentiate between the two, this question: do you want to measure current practice against evidence-based clinical standards? If the answer is yes, it is a clinical audit. And in this table, just to share with you what are the differences. So, like for example, the aim of a clinical audit and the aim of a research. The aim of a clinical audit is to establish what is the best or more effective practice of the research. For a clinical audit, to evaluate how organizations resemble the best practice. Okay, and when it comes into who initiates the research and a clinical audit, research is definitely by researchers, clinical audit, as I said, by national bodies or care providers. In research, it's asked, what is the right thing to do? A clinical audit asks, are we doing the right thing? Results are compared with a hypothesis or a prediction, and here it is compared with a standard. The methods are almost the same. The outcome of a research, definitely it will help in improving the knowledge about that area. For audit, it will improve the practice. It will improve our knowledge, but it will improve the practice at the end. Reports for a research are usually open. For an audit, it is limited to the specific group, or it can be made wider, depends on the agreement. Afterwards, other people will repeat the same research, asking the same question or other questions. But for an audit, the practice will change and re-audit is done for the same area frequently. So this is the difference. And in fact, briefly, how to make a difference between a research and a clinical audit briefly. Are we singing the right song in a research? And in a clinical audit, are we singing this song right? This is, in another terminologies. And for a research, it seeks new knowledge. Whereas a clinical audit, it seeks to ensure that existing knowledge we have, the latest based evidence knowledge, is being put in practice, is being practiced by all of us to improve the quality of care. I'm sorry if I am fast, Dr. Ali and colleagues, but I thought to share with you this basic information. As I told you, it takes me 3 days almost to do this audit. So now the floor is open for any answers, questions and queries or suggestions from your side. Back to you, Dr. Ali. Jazakallah khair. In terms of the number of the patients or the scope in terms of the services we include. And there is, in fact, as I said, quality impact analysis in which there is something or some sort of system you will do to identify which service that I'll start with first. It depends on, for example, as I said, if that service is used by large number of patients, and I want to make sure that those patients are really getting the best service. Is it a high risk service? Like, for example, open heart surgery, it is a high risk service. Is it high cost? It is high cost. So you will put certain criteria, you will give scoring, and then at the end, based on these 5 or 6 criteria, and based on the scoring of each of these criteria for that service, you will decide, okay, I have 10 services, but for me, service number 1, I'll do it for, say, for example, rheumatoid arthritis. I'll start with rheumatoid arthritis as one of the main services that I'll do this year, because it is, highly costly, high risk, seen by a large number of patients, and it also carries dissatisfaction among patients, for example, if they are not well treated. So there are criteria for that.
What about the confidentiality of the data? How do you deal with the data confidentiality in audit?
Yeah. This is a very good question, Dr. Ali. And in fact, as I said, we start with first of all, the culture, and then the environment, and then agreement with the administration, the hospital administration, the department administration, and make sure that we have an agreement before. So when it comes into sharing the data, definitely you will not share names of patients, and you may not share also names of physicians or names of the teams. But at the end, you have to share the outcome of that analysis with the head of the department, with your peers, for example, and definitely with the quality assessment or quality management department and the hospital administration. But as I said, it has to be with a positive culture for the sake of improving the service and not comparing between clinicians or pinpointing, those physicians who are, or teams which are low performance.
Thank you. Any question from the audience? In many centers, personnel are overstressed with the duties and responsibilities. So they need resources to conduct audit. Yeah. How do you deal with lack of resources and limited personnel?
It is a very good question, Dr. Ali. And to be honest, this is my personal view. And I faced it when I was at the university, and also when I was in the Ministry of Health, moving to some hospitals, moving this culture and shifting this culture. To me, to be honest, I feel it is wrong to bring people from outside, do the audit and the exercise for us. We have to have that sort of practice in our day-to-day work, and we have to have the culture. We have to have the positive attitude to do that practice. I am the expert, say, for example, in family medicine or in rheumatology. I am the expert, and I am the best person to judge whether that service is given up to the evidence or up to the standard, expected standard, or not. And if you bring a team from outside, they'll do the exercise for you. They'll submit to you a report. You feel there is no ownership. You have not spent time on it. You have not felt how painful and how costly this part or this exercise. Yes, at the beginning, it will cost you time. You will say, I have a lot of patience, but at the end, it will build your knowledge, your capacity in doing it. You will shift this experience to others. So at the end, it has to be done by the team themselves. Yes, they may seek the help of some staff to help them, but it has to be done by the team.
Any question from the audience, please? Any questions? Is there a system to ensure different health institutions will conduct audit periodically? That's the question from the audience.
Yeah, sure. I mean, this is what I meant. It has to be it has to be structured, within the whole institution or organization. It has to go through. It has to go as a program. Like, for example, when I was in the Ministry of Health, we decided to enroll hospitals into what is called Patient Safety Friendly Hospital Initiative. And I remember we made a plan for the 9th 5-year strategic plan, 2016 to 2020, by 2020, to include all private hospitals and all Ministry of Health hospitals and some non-Ministry of Health hospitals. And we decided that this is going to be regular. Every three years, there'll be a major audit, and in between there are minor audits for several departments, either self-assessment or an external assessment with reports to be submitted. So whenever there is a system, departments or institutions will definitely adhere, especially if that monitoring system is really strong enough to say to hospital so-and-so or institution so-and-so, you have not done it after a year or 6 years or 6 months or maybe more than 2 years. So there should be a system structured within the organization.
Is it acceptable to have different standards between different institutions?
To me, if it is in the same specialty, the same area, it is really dangerous, because the same patient may be served by, like rheumatology, for example, or diabetes care, or because the same patient in Ibri, for example, who is a diabetic patient with hypertension or hyperlipidemia, may go to Ibri hospital, but sometimes he or she may go to University Hospital or Armed Force Hospital or Royal Hospital. So it has, to me, as a national system, it has to be one standard. That is the best practice that we follow. Having different standards will not serve the ultimate aim of improving care at a national level.
Thank you. Any question from the audience? Dr. Ahmed, closing remark for you. So please, if you wanted to add final words of wisdom to your lecture.
Sure, Dr. Ali. So in fact, as I say, the second half is also almost the same time, but we are left with 5 minutes. I will give I'll just go quickly. There are many terms that you will come across when you talk about clinical audit. Like structure, as I have shown here, structure, process, and outcome. And this is the structure of any healthcare system, any hospital. Structure, it means the resources, the facilities available, the environment, the culture, the staff. The process, how I utilize these resources, the money, the drugs, the laboratory facilities, the radiological investigation, support, and the guidelines, and the outcome, which is either patient outcome in terms of, they call it desirable, relief of pain, satisfaction, or undesirable, like, for example, deaths, and even staff satisfaction. Another term, which is criteria or criterion, they call it. It is systematically developed statement that can be used to assess appropriateness of specific healthcare decision. I'll go fast. The other terminology is standard. It is the statement of the expected and accepted level of performance and quality that are made available prospectively to healthcare organizations through a formal mechanism and are used for the assessment or the comparison of the organizational compliance and performance. I'll go fast. Another terminology is indicator, which is the actual measure of, or a measure or a flag of the actual performance that determines the extent to which it implies with a standard or guideline. And I'll just give you example of how, and we have something called target. It is expression of desired service performance, for example, output or coverage desired to be achieved at some time in the future. It is synonymous for that is the aim, the end, the purpose, and the goal. And we have something called objective. So now I'll share with you examples of this, if you allow me, Dr. Ali, to make it clear.
Please.
Now, when it comes into, say, for example, the structure, the facilities available, the equipment, the staff, it says here, for example, number 2, patients will be seen within 10 minutes of their appointment time. If, say, they go to any of the clinics. This is an example. Now, when it comes into the indicator, it is the proportion of patients who will be seen in 10 minutes time. That's an indicator. It is like a red flag. A flag. It tells us how many have been. The standard here, it says now, currently, I'll be able to see 90% of my patients within 10 minutes of their appointment time. But the target, I'll be able to see, say, for example, by the end of 2023 or the end of 2022 or since 6 months' time, I'll be able to see 95% because I'll be adding some clinics, I'll be adding some nurses or clinicians. Another example, when it comes into process, like for example, patients with stroke should be treated with platelet inhibitors within 48 hours after admission. The indicator is how many of them have been treated within 48 hours with platelet inhibitors. For me as a hospital, I can do it for 90% of patients because I have enough resources. But after 6 months, for example, I'll be able to do it to 96%. Now they are this gray colored one, they are something, it has to be done by 100%. Like for example, when it comes into trauma patients, the Glasgow Coma Scale should be documented for all trauma patients coming to A&E. This is something a must. We cannot go beyond it, below it. 99.9%, it means a failure. So it says here the standard 100%. And I will keep it all the time. Anytime, that it will come. The same thing here for the outcome, the difference between the criterion, the indicator, the standard, and the target. Now, the stages of a clinical audit, Dr. Ali, sorry, I just take 5 minutes of your time.
Please go ahead. Go ahead.
Thank you. There are, 5 stages, as shown here. It starts with preparing for an audit. As I said, doing the initial work, combining the team, identifying who are members of that team, putting a target of that service, selecting which service or which item of that service to audit, identifying the number of the patients, identifying the tools that I am going to use, data collection tools in my assessment. And then you will go to selecting the criteria, the standards that you will follow in order to say, yes, I'm doing well or not. The criterion for that service. Measuring the performance, doing the data collection, making improvement, and sustaining the improvement itself. Now, I'm sorry, just I go back to one of this is an example, Dr. Ali, in rheumatology. Like, for example, patients should have a record of disease activity at each clinic visit. The standard is 80%. Patients should have appropriate urine protein quantification, 90%. And you may say, okay, in 6 months' time, we want to reach 100%. So these are examples. Patients on hydroxychloroquine should be on less than 6.5 milligram per kilogram per day for 95%. But I may target upper or lower rates. So these are just examples. And then my last recommendation, Dr. Ali, I'm sorry if I'm fast, but as I said, it takes the process of clinical audit should be at the core of any system. Any system, either regardless of its size, a department, a health center, a hospital at different levels, or a system in general, and any organization. So monitoring through different tools, including the clinical audit, is very important. Otherwise, we will not be able to secure a good quality service or even securing safety of patients. Clinical audit must be fully supported by, say, for example, Ministry of Health or university or AFH, for example. Access to the necessary time, facilities, advice, and expertise is needed. As you have mentioned, Dr. Ali, establishment of Central Clinical Audit Office, that was a recommendation that given to when I was in the Ministry of Health. Clinical audit should be compulsory for all healthcare professionals providing clinical care. It is an ABC of our practice, current practice. And I remember now in UK and in USA and in Canada and in many other organizations or systems, I cannot recertify my certificate unless I show them, I don't know how many hours, a number of hours a year that I carried a clinical audit activity. I'm not sure in rheumatology, I'm sure maybe you know it better than me, that I cannot get my recertification in the Royal College of Physicians, for example, unless I showed them that I have done this number of hours as a clinical audit activity. And the same thing should be applicable in our system. Otherwise, we will continue delivering a service without knowing, are we in the right direction? Are we developing, improving, and excelling, or we are static at one level? So, Jazakallah khair, Dr. Ali and colleagues. I'm sorry if I'm fast, but because of the time. Thank you very much.
Thank you, Your Excellency. Any question, please, from the audience? Now, Your Excellency, you know that you brought the Bristol inquiry that ended up, or even before it, with people actually struck off the register and being permanently not allowed to practice.
Yeah.
So that sometime audit can be also can be tough on clinicians.
Exactly. And that by itself, in fact, yes, to us it was a bit harsh, but it sends a very tough and strong message to all of us that I think when it comes into people life, there is no excuse of making sure that we go to the higher levels of expertise in providing the service. So I fully agree with you, Dr. Ali. Sometimes some decisions are really hard and harsh to accept, but there is no escape from it. We have to do it that way because we deal with lives, lives of people.
Thank you. Any question from the audience? Thank you, Your Excellency. We really enjoyed your talk, and we were wishing to see you physically in Muscat, but because of the COVID-19 pandemic and the regulations, that we could not actually have our meeting physically. We did all the preparations, including hotels, accommodation for all our delegates and everything. But that has to be cancelled last minute.
الله يحفظكم ويوفقكم دكتور وانا في خدمتكم يعني وان شاء الله نلتقي على خير في وقت اخر باذن الله.
ان شاء الله تعالى.
جزاك الله
خير. شكرا
شكرا
جزيلا. احسن. حياكم الله.
مع السلامه. الله يحفظكم.
جميعا ان شاء الله.
Hi, everyone. I'm Dr. Zakaria. Welcoming you all to the second GCC country conference. We are hoping to make this conference actually as in person. However, as you know, COVID went again. Today we have the workshop about the practical approach to interpreting of the immune labs, Pitfalls and Pills, done with Dr. Jalila Al-Shekaili. Just few words about Dr. Jalila Al-Shekaili. She's a consultant immunopathologist in Department of Microbiology and Immunology at Sultan Qaboos University Hospital. She has a fellowship from the Royal College of Pathologists of Australia. After her clinical immunopathology training, she did her PhD of immunology, immune deficiency at the Australian National University. Currently with her colleagues also responsible for provision of the immunology, diagnostic services, autoimmunity, allergy, and immune deficiency to Sultan Qaboos University Hospital and many non-Sultan Qaboos University hospitals. Welcome you, Dr. Jalila, to this workshop, and the floor is yours.
Thank you very much, Dr. Zakaria. I'll just share the screen. Is my screen there?
Yes. Yeah.
Okay. Good. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Zakaria, and thank you, the organizer, for inviting me to give this workshop in the second GCC rheumatological conference. I have no conflict of interest to declare. So the outline of this workshop gonna be divided into the first part of it. I'm gonna talk purely the usual autoimmune stuff, you know. So I will talk a little bit about some background in methodology, like for ANA, ENA, double-stranded DNA, and ANCA. And then I will follow that with some cases. Those cases gonna be interactive, so please give me an answer whenever I ask to make it more useful. The second part of the talk is basically based on request of some members of the Rheumatology Association. I have been asked to talk about complement. So I'm gonna talk about some basic, again, background, some testing of complement deficiency, and then some cases. Okay, so what is an autoantibody as an ANA, for example? So antibody is a protein made up by B cell after recognizing a foreign protein, and usually that is toward an infectious organism. And it's usually, again, it's a normal needed process or response to fight an infection. But then, as in ANA, it's a type of antibody which recognizes some natural occurring protein in a given microorganism. So it's to a self-protein. And the presence of an ANA or this antibody in the right clinical context, it could be supportive of a specific autoimmune. So for ANA, it could be supportive of lupus. And the absence of this autoantibody, especially the ANA, does not, in the absence of compatible clinical presentation, a positive ANA does not mean anything. So we do see a lot of positive ANA without any clinical significance. Interpreting autoantibody profile, we should know that we have different also isotypes which we deal in our labs, and it depends on the test being requested. So for example, in gluten gluten autoimmunity, our tests are based on IgA. So what we detect in our lab is an IgA-based assays like TGA or endomysial antibody. For example, antiphospholipid syndrome, as you know, we can order anticardiolipin, beta-2, and they are of an IgG or IgM. For most of the autoimmune serology which we do, they are usually against an IgG, and we detect an IgG-based test. Some antibodies have low affinity and avidity, and that can give you a false positive. Usually it is of a low titer, especially in something like ELISA. Some antibodies have a high affinity and avidity, and those usually will give you a true positive, especially in methods like indirect immunofluorescence and line blot. So this is some of the general information. For ANA, the methodology which we use in our lab, and it's the recommended or the gold standard method, is the indirect immunofluorescence, which is at best is semi-automated. It needs an experienced personnel to perform and report, because you read a titer as well as a button. The advantage of doing an ANA, it gives you, the luxury of detecting more than 100 possible autoantibody. Substrate used to detect ANA, the usual one or the classical one is HIP2, but then there are variants with some enhanced characteristic. So HIP2000, for example, substrate have more ability of detecting Rho60, while HIP210 substrate has more enhanced capability of detecting some more mitotic cells and more specific pattern, like centromere, for example. And as I said, IgG is the conjugate which we use to detect ANA. What about our screening dilution? Our screening dilution, you can use different screening dilution. You can do a lower one, you can do a higher one. But then doing a lower one, you will detect more normal, and more normal people will have a positive ANA. And then the higher the titration you use as your screening dilution, you will have less number of normal people that are going to be positive for ANA, for example. So which cutoff you should be using? For adults, it's been agreed that it should be locally determined, and it should be a titer related to the 95th percentile of a healthy control, where you can kind of differentiate between a healthy control versus those with rheumatic disease. For a pediatric, there is no consensus, but it has been seen again and again, those with a low titer, mostly non-significant. So for reporting ANA, we have done ANA. How do we report it? We report it with a titer as well as with a button. And the higher the titer, so this is our reporting titer, and the higher the titer is the more concentrated antibody you have in your serum, is the higher chance of having a clinical disease. Does not reflect severity. So a high titer does not reflect a severe lupus, for example, versus a low. You can still have a low titer of ANA with a good positivity of the follow-up test and a good going clinical disease, okay? So the higher titer is the more likelihood you will have a disease. And then also we report ANA with a button, and that will help us in predicting which ENA specificity we should be predicting, as well as clinical association. So these are the common ANA button which we see. We have incubated serum of a patient on a substrate of HIP2 or any of those variants of HIP2 slides, and then using IgG conjugate, fluorescent attached. Under the fluorescent microscope, we see different patterns. It's a very nice patterns here, okay? So we have homogeneous, speckled, nuclear dots, nucleolar, and different patterns. And all of them, you can see there is a nuclear staining inside, okay? Whether it's a homogeneous staining or speckled or dotty or whatever. Versus this one, the nucleus itself, it's not staining, it's negative. But then we have a good going fluorescent cytoplasmic. So all of those, we report them as positive ANA. And this one is a dead negative. There is no fluorescence, whether in the nucleus or in the cytoplasm. So this is a clear-cut negative one. This is the way how we report ANA. And there are many different buttons beside those, but these are the common one. Is ANA by indirect immunofluorescence is the only way? No, there are other ways of doing ANA, especially for a smaller lab. You can do it also by ELISA and line blot. The advantage of those, they can be automated better than indirect immunofluorescence, which is semi-automated. You don't need to have that much of experienced personnel. A person who is experienced in any ELISA, in any blot, can do it and report it. But the very limiting factor about the use of ELISA and line plot as an ANA screening method is the limited autoantibody detection. So it has a high false negative rate, meaning if you have a strongly suspecting clinically wise a patient with lupus or any other connective tissue disease, and you have an ANA negative by one of those methods, you should still proceed with indirect immunofluorescence because it still can be a positive ANA. Okay, so this is just a summary kind of an ANA testing. The indirect immunofluorescence is the gold standard when in 80 titer is a reasonable. The higher the titer, the more likelihood it's clinically significant. And then we do the follow-up. What about the follow-up tests are usually extractable nuclear antigen, ENA, or double-stranded DNA. How do we do them? We do them, can be done usually by ELISA or line plot. ELISA, you can do so many samples in one plate, but then the disadvantage, it gives you negative versus positive, and then if it's positive, you have to do a secondary ELISA or a second method to define the specificity to which it is positive. While line plot, you can do only limited number of samples per run, like 16, for example, here, but then it is screening as well confirmatory because it gives you, it is positive to which specificity. Double-stranded DNA, again, there are different methodology of doing it, and each of them have a different sensitivity and specificity. In our lab, we were doing ELISA as a screening method, followed by indirect immunofluorescence as the specific method to confirm it. We have shifted from ELISA into a more recent methodology through FADIA, which is a fluorescent-based immunoassay. So the recommendation for assessing double-stranded DNA, basically using a screening method and confirmatory method. Vasculitis, the one, primary vasculitis, predominantly small vessel vasculitis, the one which we deal in the lab is the ANCA. So, and the recommendation for ANCA testing is as follows. We have the serum and then we use a specific substrate for ANCA. Usually it's a formalin fixed and it gives you a specific pattern. We call it C-ANCA because it gives you a cytoplasmic staining. And then we use a different, another substrate, which is an ethanol, and it can differentiate between the B-ANCA and the C-ANCA. And we follow up this one. So this is the appearance on indirect immunofluorescence. Both of them will give you a C-ANCA on formalin, and on ethanol, you have the C-ANCA here and you have the B-ANCA here. The perinuclear or the nuclear staining. And you can see here the nucleus is dark while the cytoplasm is staining. We follow up this with ELISA. Why? Because not all B-ANCA is MBO and not all C-ANCA are BR3. You can have other specificity that are not significant in ANCA-associated vasculitis. Any questions so far?
Any questions from the audience? So you can turn the mic and ask directly or send us a question in the chat.
No? Okay, we'll proceed. Yeah. So these are cases, and please, I will need an answer. So the first case is a typical easy case. 12 years old girl, had a history of progressive fatigue, multiple joint pains, fever, facial rash, extensive hair loss. And she had also an ulcer for a few months. Her complements were low, her ESR was high, CRB is normal. So what do you want to order?
Anyone in the audience? Yeah, I think no one is here, so we can.
So no answer? Come on, it's a straightforward. No? I don't know, do you see the, my slide there? Do you see the green one? Okay, good. Oh, sorry, it went fast. So we have done, yeah?
Yeah. Just Dr. Ali saying it's probably a SLE case, so.
Yes. Yes, so thank you, Dr. Ali. At least I have someone who have responded. Okay, so ANA was positive, homogeneous pattern, strong titer. So that's our comment. ANA with homogeneous pattern most can be associated with lupus, but can be seen in others. And we need to do the follow-up test to see. Okay. So our follow-up tests have identified strong positive ribosomal B, Smith, and SSA, as well as positive double-stranded DNA by the screening, as well as by the confirmatory. So as I said, this is a straightforward. It's a typical serology of lupus. The second case.
Before going to the second case, Dr. Jalila, somebody in the chat saying that is cytoplasmic ANA a real ANA positive, or it should be considered negative?
No, they are positive. We report them as positive, as well as according to the international recommendation, they should be reported as positive. And we do a follow-up test based on ANA. Especially sometime we have seen it and have presented in the past where we have a ribosomal, a pure ribosomal with nothing else will give you a negative ANA staining as such, but it's a positive cytoplasmic. So you might miss those among other diseases, but then I'm talking now specifically about lupus. So no, cytoplasmic should be reported as positive ANA. Yeah? Good.
Yes, and no more question. Yeah, we can proceed.
Okay, good. So the second case is, again, another easy case, 12-year-old girl known to have sickle cell, running very mild course of disease. And then she had this 3-month history of weight loss, generalized body weakness, and hand swelling, low platelet. Could this be lupus? Her C4 is low, her ESR is high, CRB is highish, and then her NA is positive. Could this be lupus?
Audience? So you have C4 is low, ESR is high, CRB is high. Patient has some symptoms and low platelet as well. So somebody saying is yes?
Yes, okay, but we still need to do the follow-up test, yeah?
Yeah.
So our follow-up test is the ENA and tend to be nucleosome, but double-stranded DNA was weakly positive by ELISA and was negative by the confirmatory test. So who said it was lupus? What do you think serology-wise is this is lupus or not? A positive ANA, nucleosome strong positive, double-stranded DNA basically negative.
So from the audience, yes, it could be.
Yes.
Double-strand and DNA positive.
Sorry, double-stranded what?
They said it's double-strand. There is double-strand, yes, in the beginning, but not the confirmatory.
Yes.
Yeah.
Yeah, so I will regard this one as double-stranded negative, basically.
Negative.
So
Yes.
a positive ANA with the nucleosome on plot and negative DNA. Is this serology-wise lupus?
So audience, what do you think? So someone said it's could be hepatic disease.
Hepatic disease.
Yes, somebody said yes because it's nucleosome.
Exactly.
Positive.
Yes. Yeah. Excellent. So nucleosome, and this is for the criteria. So nucleosome and double-stranded DNA negative, actually, it is useful marker for diagnosis as well as activity assessment, especially in dsDNA negative as well as Smith negative. It has a sensitivity of 61 and specificity almost up to 98%. And data from meta-analysis have both nucleosome almost at the same level or even superior to double-stranded DNA. So yes, a positive ANA with a positive nucleosome, especially if it's a strong one, it is highly suggestive of lupus, even if your double-stranded DNA is negative. If double-stranded DNA is positive, of course, it makes things much easier. Okay, third case. This one might be tricky. So 21 years old male was seen with some non-specific musculoskeletal pain, generalized, not located to a joint, more of like generalized to the whole body, no synovitis as such, no morning stiffness, no constitutional symptom, no other symptoms basically. And of course, ANA was done. So ANA tend to be positive to combined pattern, homogeneous as well as speckled. What do you think of this? Should we do a follow-up test or that's it, or?
So basically at 20 years without like specific symptoms.
Yeah.
And positive ANA of 640.
Yeah, so it's a good going titer with a common pattern, homogeneous and speckled.
So it should, I think in the chat there is like the answers is taking some time, so we need to wait slightly for the audience.
I'll give you an extra tip. It's our protocol that ANA, regardless of whatever the clinical history, if it's a positive, we do the follow-up test. And in the follow-up test, in the ENA, there was this strong positive, what's called the F70. Double-stranded DNA by ELISA was negative, so we did not proceed with indirect immunofluorescence. Any hint there? Is this significant? Should we just dismiss it? Not follow up the patient? Should we call him in few weeks, few months to come back and reevaluate and see how things they tend to be?
So from the audience, somebody said, yes, we probably need to repeat and or adding complement.
Mm-hmm.
And yeah.
So is this after the DF70? No?
So no comments about the DFS70?
Anyone? Any idea? Does it have any clinical significance? Does it push toward autoimmune disease, connective tissue disease, or it says no, there is no?
Oh, somebody's saying is reassure the patient. It's normal as long as there's DF70.
Thank you. So yes, DF70, dense fine speckled of 70 kilodalton. It has a prevalence of 1.7 in the whole population in one study, with 4.6 to 10% of the ANA positive they have done. And usually it is reassuring, but it has to be its exclusive presence. So there is no other ENS specificity, there is no DNA there. Then most likely this is not a systemic autoimmune rheumatic disease. Good. The following case, 40 years old lady admitted with a history of psychosis. Are we going on a good base or it's too fast for you guys?
I think just because, I mean, the answers is taking some time to appear in the chat. So yes, we might need to give some time.
Yes, when it went from physical to virtual, I said, oh my God, we'll see. Hopefully we'll be there. We'll get it there, inshallah. Okay, so this is 40 years old lady admitted with a history of psychosis, 1 month history of headache, behavioral changes, poor appetite, and weight loss. And on the initial request, we had the request for the following, because it was not a straightforward psychosis. They want to rule out other organic causes. Her ANA was negative, and we do in our lab neuronal testing, limbic encephalitis screen using indirect immunofluorescence to those commonly detected specificity. And we do another neuronal screen through a line plot in what we call paraneoplastic screen, BSS. And we use it by plot, and it's detecting 12 more autoantibody neuronal. So we have altogether 12 plus 6, 18. And both of them, they were negative. And this was actually from a different lab, has sent this request to our lab. And then we got a call the second day after we released the results. No, our rheumatologist insisting this is a lupus and he needs an ENA and DNA. We said, no, we cannot proceed unless you give us more history, because based on this is nothing. And we have reviewed our slides again and our plots, and it was a clear negative. So the given history later was, there was also a malar rash. There was a history also for hair loss, and there was also a history of proteinuria on the top of a microcytic anemia, high ESR, and low complements. And of course, we went and repeated NA, and this time it was positive, strong positive speckled. ENA was a strong positive for different specificity, including Smith. Double-stranded DNA was negative. Antiphospholipid screen for anticardiolipin as well as beta-2 glycoprotein. For the IgG and IgM, all of them, they were negative. So then why did we miss the NA the first time? Any thoughts?
So the first test was done through immune fluorescence and
Yes.
was negative.
Yes, and we have read the slide again, and it was negative. So it was not a reading issue. And the second time we have repeated, it was a strong positive. So can you give me reasons why there was a negative, or a reason for a negative NA, that if you do later, it is a positive, or you find out it was a positive one?
Audience, any explanation for that?
No?
Yeah, that might take some time till they will answer in the chat, yeah.
Okay, I'm concerned about the time. Okay,
Yeah.
so wrong sample, it starts from even collection. You might have sent to the lab a wrong blood tube, or it came also to a wrong backup of the sample when the scientist has done the test. So the solution to that is to recollect or rerun the test, wrong dilution, which have been used, or a brozone, and that is when you have too much antibody in the patient serum. Substrate issue, so your kit or your slide is not good. You need to do or use another new kit or a new lot with a quality sample, which we use in each run. Reading, so if you have inexperienced scientists, reading the slide can give you also a negative. Calling negative and positive sometimes can be tricky. Or transcription error. Remember, ANA indirect immunofluorescence is at best is semi-automated, so you have a human factor at all steps, okay? But then we, in our lab, we have also second level of checking. For that specific sample, it was actually a substrate issue. So when we have repeated the sample, the same sample, we did not recollect, the same sample, we have used it on another lot of slides, it tend to be a strong positive. So
there is an answers from the audience. Some of them said could be because of the excreted by the proteinuria. That means the ANA.
Not to that extent. No, I haven't seen proteinuria causing the ANA to disappear altogether. You might have a low level, but not altogether, unless the patient is an immunodeficient, basically an IgG deficient, or have received an IVIG, for example. But we have rerun the same sample, so it's unlikely all of those, and it's to do with the substrate. So history and communication is always crucial. Okay?
Good.
Good. Okay, the second case is 15-year-old teenager girl with 3 to 4 months of arthritis, hair loss, minor rash. 3 weeks back started to have basically bruises, hematuria and epistaxis, hemoglobin of 9, low platelets, hyretics, and positive DCT, and has received an IVIG. And then her team has decided to send an ANA. So her ANA was positive, 1320 speckled pattern. And as I said, once ANA is positive, we do the follow-up test. Her ANA came to be weak, positive for SSA and Smith, and double-stranded DNA by ELISA was positive, but then negative by indirect immunofluorescence. So could this following serology be lupus or not?
So the patient received IVIG for the platelet sake?
Yeah.
Yeah. Audience, any thought? So it takes some time, but
No?
till the, yeah.
Please.
Still, I mean, we need to wait some time till the answers appear.
If someone is typing?
Yeah, so. You can see, yeah. It takes at least 1 minute till the answers appear.
Okay, then you tell me the answer later. So this was the—
I think the best way is that, I mean, they need probably to just open the mic and talk.
That would be much easier.
Which is the easiest way.
And quicker. So please unmute yourself and just give me your answer. That will be really very much appreciated. So for this one, after giving an IVIG or when they have sent the serology was positive, could it be lupus? Yeah, no. She had a positive ANA and that weak specificity of SSA as well as Smith. And then few months after stopping IVIG, this is her real serology. ANA was a strong one, her ENA was a strong one, including moderate positivity for Smith. Double-stranded DNA remained negative. So basically, whenever you give an IVIG for a patient, even if it's a life-saving, please collect a serum sample before you give and send it to the lab, or then you will have to wait at least 1 month. IVIG can give you a false positive, can give you also a false negative result. So you might mismanage the patient later on if you send the sample soon after IVIG and you depend on that results only. Okay. Yeah? Should I keep going? Okay, so my following case is a young woman with a long-standing rheumatoid arthritis, long-standing etanercept and methotrexate. And for the last month before presentation, she had basically a renal impairment. She had headache, visual disturbance, high BP. Her renal function months before this episode was totally normal. On presentation, she had basically an acute renal injury. And among the workup and management, of course, you need to rule out other causes. And so we got the following request with the following results. She is a non-rheumatoid arthritis. So her CCB was strong, high, RF was positive. Her, for the acute kidney injury, she had ANA, she had ANCA and GBM. ANCA and GBM is negative. ANCA, I would call this one is negative. Though it is immunofluorescence is positive, but since MBO, BR3 are negative, it does not support an ANCA vasculitis. Her ANA is interesting. So ANA is strong homogeneous. Her ENA is strong positive for nucleosome. Double-stranded DNA also is positive. So please, please, please give me your thought. What do you think, what we are dealing with now?
So please, from the audience, you can just unmute and give your thought. So from the audience, somebody said it's probably overlap like lupus.
Yeah, rheumatoid arthritis lupus.
Yeah.
Yeah. Or maybe seroconversion into lupus. She was on etanercept for a long time. So patient on anti-TNF in general, whether rheumatoid arthritis, IBD, or others, you can see serological seroconversion, meaning they did not start with an ANA, and then with time of use of anti-TNF, they can seroconvert into ANA positive. They can seroconvert into different specificity also of ENA, including double-stranded DNA and nucleosome and others. So up to 2/3 of patients of anti-TNF can seroconvert into ANA. It takes months usually, and it can happen to all anti-TNF medication. But then clinical seroconversion into lupus, usually it's really rare. It's less than 1% would develop lupus induced to anti-TNF, and usually to infliximab, the few case reports there. So clinical or seroconversion into lupus, it's common serology-wise. Clinical-wise is not common, but it can happen.
So Dr. Jalila, seroconversion because of anti-TNF is not considered as drug-induced lupus, like other medication like hydralazine. Is that right?
Sorry, say that again.
So we have drugs also causing lupus like hydralazine, procainamide.
Yeah.
Anti-TNF can cause as well as seroconversion. Is it different? Doesn't called drug-induced lupus?
It's called seroconversion into lupus rather than drug-induced lupus.
Drug-induced lupus.
And usually it's more of a serological seroconversion, so it's more of an autoantibody. You don't have the clinical disease. Clinical disease, the one reported are more of a case reports, and usually it's very mild, and usually once you stop also the medication, most of them, they would go away. But there are some cases where they are really converting into clinical lupus, where you need to start medication to control the immune system.
And is it part of the, management is to stop the anti-TNF, is that right? Yeah.
Yes.
Yeah.
Is it more likely to happen in those who are ANA positive in the beginning? Are A with ANA positive? Or not? There's no increase?
Not really. And the one they have reviewed in that literature I have presented, they basically have excluded those who have presented with a positive ANA from the start. But I couldn't find any, I don't know if there is any in the literature, but not in the one I have seen, positive ANA before starting anti-TNF as predictor of developing a clinical lupus. No, I couldn't find.
And Dr. Jalila, is the positivity of ANCA is related to this seroconversion in this case, which is negative, if after MBO and PR3 detection?
Okay, so are you referring to this one?
Yeah.
I don't know if you recall, I have presented during the ANCA, ANA positive can give you a B ANCA in some of the substrate, but then when you do the follow-up in BR3, it is negative. So it could be just an indication of the seroconversion rather than a lupus itself.
Yeah.
Good evening.
Yeah.
Oh, hello.
Yeah, you can do. Yeah.
Yes.
Yeah, can you hear me? Good
Yeah,
evening.
yeah, we can hear you. Yeah.
I am wondering just about the double-strand DNA, which is positive with the TNF. Does the seroconversion include the positivity of the double-strand DNA, or just about the positivity of the ANA?
No, there are in some of those reported cases, they had some of them. They have a double-stranded DNA positivity. Does that answer?
Is that answer your question, Doctor?
Oh yes, thank you. Thank you so much.
So Dr. Jalila, probably the audience probably they need to differentiate between anti-TNF inducing lupus, like seroconversion, and drug-induced lupus. What's the difference in serologically? Is there any like additional markers they can differentiate between anti-TNF or drug-induced lupus?
No, not actually. It's more of a clinical judgment. And serology-wise, both of them, they will just induce basically autoantibody. But again, serology, seroconversion, it's common to many diseases. To many drugs, especially the anti-TNF, as only autoantibodies. Clinical seroconversion is not that common. Drug-induced lupus can also cause a clinical disease, but usually when you stop your medication, you kind of, the diseases start, to fade in severity.
Yeah. And I mean, we use like antihistone for drug-induced lupus. Can be happen in anti-TNF. What about the complement, the present of the low complements in anti-TNF? Probably it's not present in the drug-induced lupus.
Again, I don't think so. They are of value. I haven't seen any literature on that. Antihistone exclusive presence again of it might support, but then most commonly antihistone is present with other specificity. Again, it does not help to differentiate.
That's good.
Yeah.
Thank you.
Okay. Okay. So our next case is a 55-year-old male, history of change in his voice, basically had a recurrent epistaxis, laryngitis, exertional dyspnea, and then his biopsy, laryngeal biopsy, was suggestive of granuloma. And for the sake of the time, with granuloma, you have to order ANCA. Yeah?
Yes.
So his ANCA was positive, C ANCA, cytoplasmic, and BR3 positivity. So it was a typical case, unusual site for GBA. And that was from another lab. The following case is 34-year-old female with history of hypothyroidism, 3 months intermittent diffuse joint pains, her malar rash, some dry cough, her labs showing some anemia, lymphopenia, high ESR, normal function test, and low complement. And in the differential, it was lupus. So they have ordered ANA, but also they have ordered ANCA. ANA is positive for nucleosome, as well as, remember, also DF70, but then it's not exclusive presence, so nucleosome is there. ANCA also is positive, ANCA with a high MBO, 200. So this is a serology of lupus, of ANCA-associated vasculitis. What do we have here?
So audience, so we have a serology, could be lupus and also the ANCA MBO positive. You can again just unmute and talk.
Yeah, no?
Anyone? No?
So So this is a typical serology of lupus, as you said, and this is a typical serology of ANCA. So are we dealing with ANCA or with lupus? Basically, again, it's more of a clinical judgment. Or we can also deal with an overlap. So patients of lupus, third of them will have a positive ANCA. Usually it's MBOBR3 negative, but then some of them, they have either specificity or both. Half of patients with ANCA with post-immune GN would have also a positive ANA. But the clinical syndrome is not that common. So there was this review of a French cohort over almost 19 years, and they have seen it in less than 1%. They have seen like eight patients only with an overlap. And usually it has a serious presentation, mainly of renal, but can have also arthritis, serositis, and intraalveolar hemorrhage at presentation. Usually it's an inflammatory syndrome. And we do get this question often from our colleagues about presence of lupus as well as an ANCA serology-wise. Is that okay? Is that clear? So in summary, autoantibody detection is the essential component to support diagnosis and to monitor disease activity of different autoimmune disease. And there are some inherent limitations to those available methodology, and communication is crucial. And I have been asked also to talk about complement. Are we good with the time? Am I allowed to go? Okay.
Yeah, I think we have some time.
Okay. So I have been asked to talk about complement because, as you know, it's widely now known and accepted that complements activation play a major role in many systemic and renal limited kidney diseases, whether they are primary complement disorders or a secondary, as their presence in many different autoimmune diseases here. So what's complement? Complements are heat labile principle in serum that complemented antibodies in killing bacteria, and that's where the name comes from. There are three systems of complement: classical, lectin, and alternative. And in total, we have more than 30 proteins, and it's a cascade of enzymatic reaction with degradation products. The ultimate is the formation of what's called as membrane attack complex, which is basically a pore-forming mechanism in the cell wall, leading to cell lysis, okay? And function of, and you can see here, we have an early part of classical, we have early part of alternative pathway, and then we have a common shared terminal pathway. Function of complement comes by knowing there are patients who are deficient to the early part of the classical, presenting with recurrent infection, as well as with autoimmunity. And we have patient deficient with alternative pathway, early alternative pathway, presenting mainly with infection. And those who have deficiency in the terminal part would present basically with more of a limited phenotype with a recurrent Neisseria meningitis. And because complement activation is dangerous and can lead to inflammatory response, we have so many regulators to control its activation. And the absence of those regulators will lead to complement-mediated disease, as in AHUS, C3GN, and dense deposit disease. Testing for complement can be done through different levels. The commonly done one is C3 and C4. Each lab does it. And then we have the functional one for all the classical, total hemolytic, including the early classical as well as terminal, and then alternative pathway for the early alternative as well as the terminal. And then we have the component testing, and we have the genetic testing as well. Testing for complement is a bit tricky. Complement's protein are very temperature sensitive, so usually we tell our nephrologist colleagues to send the sample immediately on ice, and we need to spin it and freeze it within half an hour of collection. Otherwise, the complement gets inactivated, get consumed. So when you have an abnormal result, it's basically a reflection of a bad handling rather than a genuine abnormal results. And if you are assessing some specific protein, it should be done after, either before or 2 weeks after plasma infusion or exchange, if that was given one of the, as a treatment modality for the patient. Okay, here we have a typical case of middle-aged lady, married with children, no chronic medical illness, presented with an acute short living diarrheal illness, followed by dark-colored urine, facial lower limb edema, low hemoglobin, low platelet. There was some schistocytes on peripheral film, high LDH and low hapto, with a renal impairment, and she had a microscopic hematuria and proteinuria. Any ideas there what's going on there? What's this clinical syndrome?
Yeah, so audience, so middle age with area and some like hemolytic markers plus schistocyte. That's very indicative. So sending an answer through the chat, it will take time. So if you have an answer, please unmute and talk.
Sorry? I hear someone.
Hello?
Hemolytic uremic syndrome?
Yeah, it's one of the differential. So that, sorry? So the clinical syndrome is basically TMA. So what TMA is thrombotic microangiopathies, which are classified as primary. So we have primary here causes, and we have secondary causes. So primary can be hereditary, as in atypical hemolytic uremic syndrome with complement mutation, or TTB, as in Adams mutation, or can be also primary due to development of autoantibody, whether to factor H causing AHUS, or autoantibody to Adams 13. Can be also secondary due to many reasons, including autoimmune disease like in lupus, like catastrophic antiphospholipid syndrome, as well as the renal sclerosis. In response to transplant, whether a bone marrow transplant or a solid organ, or in response to infection. So all of these have been looked at and investigated first with Adams 13 and then ruling out by history or by testing before thinking about primary complement-mediated disease. So there is an algorithm. There are some international guidelines of how to investigate such patients. And from here, what we do in our lab is the autoimmune disease associated with TMA. So we do screening for lupus, as well as the ENA for scleroderma and for antiphospholipid. And then if all of those been ruled out, we do complement assessment. So for this lady, all of her autoimmune workup was negative, NA negative, ENA including SCL17 centromere, phospholipid also was negative. It has been noticed that her complements were low, sometimes C3, sometimes was normal here and there. C4 most of the time was normal, actually all of the time was normal. So having such result, does it rule in, rule out primary complement mediated disease?
Audience, any thought? So this complement C3 done over like over days or different time, yeah.
Yeah. And again, we get this question often, a normal complement, should it be there whenever we are suspecting a primary complement mediated disease? The common scenario, the usual scenario is having a low complement whenever you have, you are dealing with a complement mediated disease. So a low complement is good is sensitive, but it's not specific, because you can have specific mutation for a complement-mediated disease and you still have a normal C3. C4 in complement-mediated disease, as in AHUS or C3 or test deposit, C4 is usually normal. So what should we do next then for this lady? Her other secondary causes have been ruled out. Autoimmune causes have been ruled out. Adams 13 was normal. Her C3 is kind of on the border. Sometimes is normal, sometimes is not. C4 is normal. Are we done there?
Any thoughts from the audience? No one?
Is there any signs of thrombosis in the renal biopsy of this patient?
Actually, there was TMA, yeah.
So we can proceed to anticoagulation.
I'm asking about testing wise.
So maybe you do CH50
Yeah.
if it helps.
Okay. So you still want to proceed among complements, yeah?
Yes.
Yes, you want to more prove. Yes, we can do CH50 and AH50, but actually, again, normal results might help or might not help. And I will show you in the second case what is the panel which we do. In this case, for some reason, it was not done. So what's done is the next level, which is basically proceeding with genetics. Because she was highly suspected to have AHUS, as in primary complement disease. And actually her molecular came back as positive for this protein CD46.
So from the audience, please close or mute your.
Okay, so we will go to the second case. Girl, since the age of 6 months, had a gross hematuria. Her renal biopsy initially was reported as normal, but then her renal function started to deteriorate. Her C3 is persistently low. Her CH50 and AH50 are persistently low. And then she had also a positive family history. Her brother had a similar upper respiratory tract infection-induced gross hematuria with a persistent hypocomplementemia for C3, and then progressed into a chronic renal failure. And for both the brother and this girl, their autoimmune serology was negative. So in those, what did we do? This is what we have done, and this is what we usually do whenever we think it's a primary complement deficiency. Unfortunately, it's a send-away test. We don't do it in our lab. So for this case, her C4 was normal. Her C3 was low. Her classical pathway was reduced or almost undetected. Her alternative, so that's the early as well as the terminal, okay? Both of them, they were low. Her terminal component, the MAC, remember? That one, the membrane forming mechanism in the cell wall, was high. This is the circulatory counterpart of that. It was really high. So how do we report this? We say basically it looks like there is a dysregulation of the complement pathway. It is active. And we need to look into degradation product to decide, is it in the classical or it's in the alternative? So factor B was lowish, but then the degradation product was high, indicating there is a continuous activation in this pathway. C4D, which is the activation product from the classical, looks like normal. So the defect looks like it is more of the early complement pathway dysregulation. Factor H, assessing factors specific levels, was low. And this is actually was confirmed by molecular. So this patient had factor H mutation, leading to her C3GN as defined by her biopsy. This is the last case.
The presentation of those cases in adulthood, but usually you would expect them to show up early in childhood. Why do they? What is the trigger that makes these patients present late in their life?
Actually, it is very unknown. Usually, it is an infection which precede and trigger. Some of them, they present early, like this girl. She presented from the age of few months, basically, here. And her brother as well. And he had almost a chronic renal failure at the age of 10. But some of them, they present late. They're waiting for like a trigger for their complement dysregulation. What is that exact trigger for all patients? It's not known.
To finish with comments on complements, there are many diseases that also cause increased complement level when you do them.
Yeah.
So how does that help you in terms of advising clinicians?
Okay, I'll go back to one of my initial slides. Why I have actually been asked to talk about complements is this one. We have so many, as I said, we have so many diseases, especially the one related or you're dealing with as rheumatology, which has activated complement, whether you see it in the serum or you see it on the renal, because kidney is very prone to a complement activation. Those primary ones usually being dealt by nephrologists. The others are being dealt by you guys or others. So a low complement, as I said, testing-wise, it's very cumbersome. It's very temperature sensitive. You have to be careful in interpreting an abnormal results, because it can be due to just an ongoing immune complex, due to infection, can give you abnormal result of complement. But then a serial abnormal result, if it is in the right clinical context, it's very supportive. And usually how we take it and how we advise it, it's again, it's history and communication. What do they think? What do we think about the results being seen in the lab? Is it consistent? Is the sampling handling is correct? And then we take it from there. Most of them, they are degradation, but then we have also the one which have a high complement as inflammatory response. ANCA, for example, is an inflammatory disease where complements are not expected to be low. They are more of high if it's not normal. If it is low, then I would expect something else is going there. Does that answer your question, Dr. Shirawi?
Yeah. Yes, yes. Thank you.
Welcome. And I think we are already running out of time. So
yeah, I think just to complete all the slides. Yeah.
So I have only 2 more slides. This is a typical case of AHUS, have a complete resolution after use of eculizumab. Is there any evidence of AHUS or complement related defect? We have sent serology and it was negative. And we have sent genetic and came back as a non-significance, a variant homozygous for a non-significance. So this is a primary complement-mediated disease? For the given information so far, basically we don't know. This patient has to be monitored, and we'll see over time how it evolves, because the reported mutation is not commonly reported to be seen by in patients with AHUS. So in summary, for complement is a cascade of catalytic activation of sequential component, emerging evidence implicating complement dysregulation in a wide range of kidney diseases. AHUS is important in the differential of patients presenting with TMA. Measurement of C3 and C4 is useful, but again, you have to be careful where a normal result does not rule out primary complement or even a secondary complement related issue or disease. I'm acknowledging my lab, and this is some of the references, and thank you. Any question?
Thank you, Dr. Jalila, for this excellent presentation. Any questions or comments from the audience?
Thank you, Dr. Jalila. What about single-stranded and double-stranded DNA reporting now? We see it more often.
Single strand, we don't, you mean like in our lab? I don't believe really on single strand. We report double-stranded DNA because it's the one which is commonly has a clinical significance with lupus. And for double-stranded DNA, as I said initially, it's recommended to do a screening and then to follow it up with a confirmatory test. So our screening was ELISA, now it is a fluorescence-based immunoassay, and the confirmatory test usually in most labs, including our lab, is indirect immunofluorescence. However, an absence of double-stranded DNA altogether, whether by one methodology or both methodology, does not rule out lupus in a clinical convincing patient. You will have to rely on others, complements, thrombocytopenia, platelets, ANA, maybe ENA, nucleosome as well, but not double-stranded DNA. So its presence, yes, would support. Its absence does not rule out. Yeah.
Any other comments? I'm sorry for the audience. We couldn't answer all the questions or read all the answers comes in the comments because it takes some time. Dr. Ahmed mentioned with the case of SLE with the ANCA that it's common to happen. And is there any rule to proceed to thyroid antibodies?
TBA by its thyroid antibody, why? She was, that was I think, was the hypothyroidism was already on treatment.
Probably.
But if you want to confirm, it was autoimmune thyroiditis, yes. But I don't see it in relation of lupus and ANCA overlap, serology or clinical wise.
Dr. Jalila, apart from the DFS70,
Yes.
how significant as a malignant marker purely positive ANA with negative other things? That should we worry? Should we screen people losing weight, or they have other?
What do you mean malignant marker?
No, not malignant marker. Should we worry in a patient with only positive ANA to see this may be?
Okay, a single purely ANA, nothing else, no ENA, no DNA.
Yes.
From serology point of view, no. Purely ANA, no ENA, no double-stranded DNA, no. But then you can see patient with good going lupus with only ANA, but then you have other supportive clinical parameter, as I said, whether hematological, skin, renal, CNS, and so on. So if you will ask only based on serology-wise, no. But you can couple it with, because as you know, criteria has changed, and the recent criteria can only depend only on one single immunological marker like an ANA, especially if you have an organ like a renal involvement, for example.
My question is that ANA is normally positive in a proportion of the population.
Yes, exactly.
And it goes up with age.
Yes.
Now, is there a higher incidence of this positive ANA in people who have malignancy?
I'm not aware, honestly. No, I'm not aware that if it is high or normal. I'm sorry, no.
Okay.
But then, does that guide you toward any specific malignancy or any specific manifestation, even if it is high or normal? I'm not sure that it has a clinical implication.
Any other comments? I think we are all done here with this workshop, and I thank you so much, Dr. Jalila, and the audience for the great interactive answers. Is there any final remarks or information you want to tell the audience?
Yeah, it's basically communication and history. If you give us your thought, what you are thinking of, and if you are not finding the answer based on the test you have requested, we can always communicate and see how's best done to help that diagnose and manage that patient. So history and communication, it's my only final remark.
Yeah, we are always saying that send autoimmune wisely.
Exactly.
Thank you, everyone. Thank you, Dr. Jalila.
Okay, thank you. Thank you very much.